Welcome everyone. Thank you for joining this video. My name is Emma Suggett and I'm Medicines Optimisation Lead for West Midlands AHSN. I'm really delighted to have the opportunity to share my project with you, in which myself and a team in Shropshire extended the transfer of care around medicines pathway to refer to clinical pharmacy teams supporting care homes. Some of the key points I'll cover in the presentation will be, initially, a refresher for you on what transfer of care around medicines pathway looks like and how this relates to the new Discharge Medicines Service in community pharmacy. Explain some of the drivers which led us to develop the TCAM pathway to support patients discharged to care homes. Show you what the pathway looks like in practice for primary care. Discuss some of our outcome measures. Finally, I'll cover some of the obstacles and opportunities for implementation. As a reminder, transfer of care around medicines, or TCAM, is a pathway whereby high-risk patients are referred on discharge through a safe and secure digital platform for advice and support from their community pharmacist. This is an evidence-based pathway, and numerous studies have shown that when comparing patients referred through the pathway who are followed up by their community pharmacist compared to those patients who are not followed up, it is the support provided by community pharmacists, either face-to-face or over the telephone, which can significantly reduce readmission rates and reduce length of stay for any patients who are readmitted. Although there are obvious benefits associated with transferring information across the interface, the impact on reduction in readmission rates and length of stay is related to supporting patients through that active intervention by pharmacists. As such, there are several guidance documents from our professional bodies promoting TCAM. TCAM is also now part of the Community Pharmacy Contract, and from the 15th of February 2021, TCAM will be relaunched as the Discharge Medicines Service in Community Pharmacy, or DMS. Essentially, the Discharge Medicines Service and TCAM are synonymous. The project to date has been supported by all of the 15 AHSNs in England who are commissioned by NHS-EI to adopt and spread national and local innovations within the NHS. And almost 50% of acute trusts now refer through TCAM on discharge. And well over 90% of trusts use the electronic platform Pharm Outcomes for their referrals, which is the same platform used for referrals to the Community Pharmacy Consultation Service by NHS 111 and now GPs, and for the documentation of NMS and flu services. The situation in the West Midlands pretty much reflects the national picture, with the addition that we have not limited TCAM to acute trusts and have a couple of community trusts who are also live, which turned out to be one of the drivers to extend TCAM to support patients being discharged to care homes. So why did we decide to extend TCAM in Shropshire? There's always been a lack of consensus concerning which groups of patients should be referred through TCAM. And although it makes sense that the elderly and frail are a high-risk group who might require support, it wasn't until last year that the first study was published confirming that indeed the over 65s specifically benefit from TCAM. It was also at a similar time that I became involved with the West Midlands Patient Safety Collaborative, who were leading in the Medicine Safety Improvement Programme for NHSE by scoping the causes of medication errors in care homes. And as part of this work, we surveyed over 100 care home staff who noted that transfer of care and poor communication was the second most common cause of medication error. As part of this scoping work, we also held a workshop for pharmacists and technicians providing clinical pharmacy services to care homes, who reported that it was incredibly difficult to target discharges contemporaneously, only picking up discharges on an ad hoc basis. At the same time, some of the trusts who were sending referrals in the West Midlands reported that they were having difficulty referring patients being discharged to care homes through the main TCAM pathway, as often residents were unaware of the community pharmacist who served the home, either because they were confused or simply that as a resident they no longer knew who the community pharmacist was. So when I received an email from the Chief Pharmacist at Shropshire Community Healthcare Trust who, due to their cohort of patients, had a large percentage of patients being discharged to care homes, we put our heads together to see if we could come up with a referral pathway to support this particularly vulnerable set of patients. And since the evidence base for the main TCAM pathway lies with that direct support given to patients through a face-to-face conversation or via the telephone, we concluded that we needed to refer to those pharmacy teams providing clinical pharmacy services to care homes. So that was either CCG pharmacists, GP pharmacists, MOC or PCN pharmacists. So in March 2020, we started the project, and this slide shows the team that I worked with. On the bottom left-hand side, you can see Susan Watkins, who's the Chief Pharmacist at Shropshire Community Trust. The rest of her team are here in uniform. And on the bottom right, you can see Kevin Noble from Pinnacle Health, who are the providers of pharma outcomes. And Kevin helped us to actually build the interface in the pharma outcomes system. The rest of the team here are from Shropshire CCG, the recipients of the referrals. So it was also, however, in March of 2020 that the COVID pandemic hit. So this had a significant impact on our project. Primary care teams were now working home-based and therefore unable to locate discharge even on that ad hoc basis as they had been doing so before. They were also being asked not to add to the workload of overstretched care home staff by emailing them or ringing them to inquire about discharges. But despite this, in May of last year, NHS England sent a letter asking that we carry out structured medication review on those patients who were recently discharged from hospital. So at this point, not only did we accelerate our go live, but there was also a renewed interest from the other 14 AHSNs in England who had similar problems in targeting discharges, and teams were frequently responsible for well over 100 homes. So what did we build? In terms of sending the referral, instead of picking the community pharmacy to which the referral should be sent, as in the top set of arrows, thus allowing community pharmacy to support the patients, the referrer in secondary care simply selects the name of the care home to which the patient is being discharged. Farm Outcomes will then send a referral to the appropriate team or individual to which that care home has been mapped, allowing the care home pharmacist, either CCG, PCN, GP or MOC pharmacist, to support either the resident directly or the care home staff looking after them. It's also pertinent to note at this point that the secondary care team are aware of the community pharmacist supporting the care home. So if they know who that person is, they then send a dual referral both to the community pharmacy and the clinical pharmacy team supporting the care home. When the referral arrives with the primary care team, they receive an email requesting that they log on to Farm Outcomes. This slide shows what the referral looks like. We designed the interface to enable us to build the evidence base for the pathway. So not only does the referral arrive with a copy of the discharge letter, direct access to the summary care record through Farm Outcomes and the patient demographics, it also allows the individual to record the consultation type, the type of intervention, for example, summary structured medication review or medicines reconciliation, and a deeper analysis of the intervention. It also has the ability to record the medication stopped, which is linked directly to DM&D, so that it's possible to cost the impact of intervention. The Farm Outcomes platform generates Excel spreadsheets detailing all of the activity documented within it. So at this point, if medications are stopped and the pharmacist or technician clicks yes, there's actually a drop-down menu where you're able to select the drug and dosage linked to a calculation of the annual cost saving. There's also a subjective analysis of whether the intervention may have prevented the resident from being readmitted, which uses a scoring system, the RIO score, which is an unvalidated score endorsed by NICE, which I'll come back to and explain in a moment. And finally, there's the ability to refer to the GP and set a date for follow-up. As I said, we developed the interface with the intention to record activity to enable us to develop the evidence base for the pathway. And I'm really pleased to say that we are lucky in that the AHSN has commissioned Hamday Nazar, who was the original researcher from Newcastle University, who published the initial research for the main TCAM pathway in the BMJ. And she'll be using the same methodology to determine the evidence base for our pathway. The intention is to cover readmission rates, ambulance conveyance and GP call-outs, a validation of that RIO score against actual readmission rates for these residents who are referred through the pathway, and a deeper analysis of the activity and interventions carried out by these primary care pharmacists. As yet, there's been very little research into the activity of these roles, particularly those new PCN pharmacist roles. So the intention is to do some quantification of the impact of these roles. So where are we now? We now have 4 live trusts in England, with a further 14 moving towards go live, with many more interested. To date, the main challenge to success has been identifying who will pay for the annual licence fee for the service, as the fee sits with the referring trust, while the evidence base for the benefit to the trust is lacking. And to complicate matters, as you may be aware, the requirement for structured medication review for residents after recent discharge for hospital now sits within the DES. So on occasion, in some systems where the responsibility will shift during the coming months from CCGs to PCNs, there's been a reluctance for CCGs to take on the cost or contribute to the licence. So in the longer term, it will be difficult to actually share, for example, the cost of the licence fee amongst various PCNs. To overcome this, while we gather our evidence base, the West Midlands AHSN is funding 9 trusts in the first year of their licence, and this way we'll be able to gather that evidence that we need. When setting up the system, you also need to ensure that the primary care team has the capacity to undertake this activity, as in most cases, one individual might be supporting numerous care homes, quite often up to sort of 50 and above. It is also possible that your IG lead might say that you need a data sharing agreement, although I would argue that if you are referring to the correct team, there should be no need for a data sharing agreement, as this documentation is already available to them as part of their clinical role should they enter a home. And to finish, there are a number of resources that are available to you, which we can offer for your backpack should you want to join us on this journey. Please get in contact with the West Midlands AHSN if you would like to access these resources, or with Kevin Noble from Pinnacle Health, who will assist you in building your bespoke service in farm outcomes to move towards go live. So thank you for listening to this video. I wish you well with your project.